Good afternoon. This is Dr. John Bennett, televising from sunny Miami. This is one in the part of the online conference for the ACNS, the Asian Congress of Neurosurgeons. Today we have the pleasure of having Professor Sridhar, a neurosurgeon from India. He's going to talk about devastating traumatic brain injury management protocols. But first, let me introduce a distinguished guest who just gave a great hangout, Ramesh Nair. Hello, Ramesh.
Hi, John.
Could you just tell a little bit about you introduce yourself, please?
You're talking. Is Sridhar going to talk, or you want me to talk
No,
about?
no, you're just going to introduce yourself for Professor's talk.
Okay. So I'm very delighted to see Sridhar after such a long time. I think the last time we met was probably in Srijitra when there was a skull base and vascular conference, and we exchanged our details, and that's the last time I met Prof. Sridhar. And we've been we knew each other for a long time, and we travel around the world. He traveled in the world, and it's so nice to see him. It's a very pioneering and very well-known neurosurgeon, and who has worked in many institutions, and he has developed a big institute on his own, to his credit. And I'm really pleased to see that he's back to his hometown, Chennai.
Okay,
And
okay, very good, Dr. Nair. Okay, Professor, could you just please tell a little bit about your life and where you practice and what you're doing now before you start your presentation? Thank you.
Hi, everybody. I'm Sridhar. I'm from Chennai, which is in the south of India. It's on the east coast. It's a seaside city and one of the 4 large metropolis cities of India, and it has a large population of people, as you can expect, and also of vehicles. I worked my first 25 years with the pioneering neurosurgeon of India, Professor Ramamurthy, and then I'm now working in an institute of neuroscience, which I head in a private hospital, the Global Hospital in Chennai. I've had the honor of editing a textbook of neurosurgery and a textbook of operative neurosurgery. And other than trauma, my interests are in vascular and spine and on neuro-oncology. So this is a bit about myself. I love teaching, and therefore here I am.
Okay.
Okay. So should I start my presentation?
Sure, sure.
Okay.
There you go. Very good.
Okay. So are you able to see the screen now?
Yes, we can see the screen.
Oh, great. Okay. So my topic is on devastating traumatic brain injury. Basically, I want to introduce this concept, which I'm not very sure that people understand it the way it should be understood. And therefore, once we try and understand the concept, I would like to then talk to you a little bit about the management protocols when we have a patient with a devastating traumatic brain injury. I first will take you over this patient who was a 16-year-old boy who came to us following a road traffic accident, basically from a two-wheeler. He was found unconscious on the roadside with vomiting and seizures, taken to a nearby hospital, and then shifted to us after 3 hours. He was received in the ER, intubated, put on controlled ventilation. His hemodynamics was stable. There were no major other injuries. His GCS was E1 VP M2. His pupils were both dilated, 6 mm, not reacting. However, he had a cough reflex with spontaneous breathing efforts. This was his scan. Now, if you look at the scan, what is very obvious is the right-sided extradural hematoma, which is there. But what is also striking to the eye is that the supratentorial compartment and the brainstem are quite dark, and that is a significant finding in this CT scan. Now, we explained the poor prognosis with respect to the pupillary dilatation, non-reaction of pupils, as well as the CT scan finding of the hypodensity of the brainstem and the supratentorial compartment. However, the parents of the teenager wanted surgery. We did a right-sided decompressive craniectomy for the extradural and to see what could be done. But however, the patient passed away. Sorry, did not pass away, but we did a brain death declaration after 48 hours and organs were donated. Now, that brings us to the point of devastating brain injury. Now, there are several names which have been given to this type of brain injury: severe brain injury, catastrophic brain injury, devastating brain injury, non-salvageable brain injury, all of which imply a poor prognosis. However, not all mean the same thing, and very often each one who describes a particular type of brain injury means something different. And therefore, what we are first going to try and do is try and see what devastating brain injury really means. So what do we mean by a devastating brain injury? The definition as given in 2009 in this paper was a penetrating and/or blunt trauma to the brain or a devastating stroke, which has been evaluated by neurosurgery. The injuries are deemed to be non-survivable and not amenable to neurosurgical intervention, and ongoing resuscitation requirements by the critical care services are done basically to maintain organs. More later, as late as in 2015, this was the definition given, where devastating brain injury was defined where there is an immediate threat to life from neurological cause upon presentation to the hospital. So this is a very a nice, concise definition which was given in 2015, which defines exactly what it means, that there would be a threat to life from a neurological cause when the patient comes to you. Now, what happens is that very often many of these patients are deemed to be non-salvageable, and nothing further is done in these in the hospitals or in the medical institutions where these patients are seen. The question arises as to whether this is right and what needs to be done actually, and how do you decide what needs to be done for which patient. Now, it's important to understand why we are specifically looking at this condition of devastating brain injury, because it's important to identify the specific patient population and not make it a general term for any patient who has got a serious brain injury. This is important because we must avoid a pessimism and a nihilism. We need to present the right picture to the family and to provide a standard of care in such a way that it gives the best chance to the brain to survive, as well as improve the functions of other organs. Now, what is important is that we must understand that what we talk about in devastating brain injury is not the same as in serious head injuries where the patients can survive. And therefore, it's very important that we tell the family exactly what we mean. It's also important that we give the patient the standard of care which is possible in all parts of the world, and we also need to look at the functions of other organs in case the patient becomes brain dead. We need to make sure that the other organs survive. It is interesting to see that over a few decades, traumatic brain injury has actually dropped. If you look at the percentage of cases of devastating brain injury, as a cause of devastating brain injury, while brain tumors and traumatic brain injuries have dropped significantly, cerebrovascular disease has increased in significance. Now, coming to the data on devastating brain injuries and their outcomes, in 1995, there was this paper on the outcome of devastating brain injuries, where of the 24 patients in whom life support was discontinued, 2 patients actually survived. And of the 23 patients whose life support was continued, only 5 patients survived. What this actually means is that whether you continue life support or you discontinue life support, where there is a serious head injury, there are patients who would survive. However, I must say that in this paper, the outcome was looked at of severely head injured patients of a Glasgow Coma scale of 7 or less, and therefore it was not really a very, very devastating head injury. This paper in 2006 looked at what happened to GCS and bilateral fixed pupils, and they asked the question, do they have any chance of survival? And they concluded that patients with a GCS of 3 and bilateral fixed dilated pupils most often died. However, there was a statement that there was a tendency in these patients for a less aggressive treatment. Now, did that play a role? We don't know. But however, if the pupils were reactive, even if the GCS was only 3, only 42% died and the majority survived. In 2009, this paper looked at the outcome of patients with blunt head trauma and a Glasgow Coma scale of 3 at presentation. 50% of these patients survived, and about 13% had a good functional outcome at 6 months, which is a very, very significant factor. And this is, I think, a very important statement which they made. And pupillary reaction, according to them, was an important prognostic factor. There was a 23% mortality with reactive pupils and an 80% mortality with non-reactive pupils. Now, just hold on for a sec and look at this statement. For non-reactive pupils, there was an 80% mortality, which meant that actually 20% of patients with GCS of 3 and non-reactive pupils actually survived. And therefore, aggressive treatment is important even if the GCS is only 3. Now, in this paper again of 2009, they looked at the survival of trauma patients with coma and bilateral fixed dilated pupils. And what they said, which is actually a very important statement, that it is very important to look at the pre-hospital GCS, because very often when patients are brought in, paramedics could be intubating patients or either at the site of the injury or on the way to the hospital. And therefore, it's important to look at the pre-hospital GCS. And what they said was, of course, that patients with a GCS of 3 and bilateral dilated fixed pupils have no chance of survival. In 2012, there was a paper in the British Journal of Surgery which looked at pupil in addition to Glasgow Coma scale, and they said that even if there was bilateral dilated pupils, a good outcome was seen in 8% of patients. Now, what does this show? A small but definite percentage of patients with a GCS of 3 to 4 and pupils bilateral dilated and fixed do survive. And if the pupils are reactive and have a GCS of 4 or more, there is a very reasonable chance of survival. We must therefore understand that we must not create a pessimistic attitude just because the patient's GCS is less than 5 or 6, nor must we be very, very pessimistic if the pupils are non-reactive. But what is, I think, very important is the CT scan finding on radiology of a brainstem infarct. These patients definitely do not survive. Now, the other prognostic factor on radiology that has been mentioned in literature is in this paper in 2012, which looks at the significance of traumatic brainstem injury on T2-weighted MRI, where the authors suggest that the T2 volumes are better to look at than the gradient echo images, and that the injury to medulla and bilateral injuries to the pons do not recover. These patients do not recover. No patient with a midline crossing lesion or a GCS less than 4 recovered when you had these traumatic patterns. And majority of patients with lesions that did not cross the midline recovered, which means that if you had a medullary injury or bilateral injuries, that is a very, very poor prognosis. The other clinical point which was brought to attention in this paper in 2011 was the response of ICP to treatment as a predictor of death. And what the authors said was that patients with a GCS of less than 9 who responded to ICP lowering treatment had a 64% lower risk of death than those who did not respond. Now, looking at all this, we need to have protocols and we need to look at which sort of patients would survive and which would not. But however, this paper in 2015 mentions that risk prediction models are often, while they have a statistical performance to support their use in research, they are not really useful when it comes down to clinical work and to guide individual patient decision making. You cannot really go by these prediction models in your everyday work.
Okay, excuse me, Professor?
Yeah.
You're on the third slide. Is that the one you want to be on?
No, I'm far beyond the third slide.
Okay, click on the slide you want to be on. That's good. That's good. Thank you.
Yeah. Are you seeing the slide now?
Yes, I am. We are. Yeah.
Okay. Oh, you were not seeing the slides before. Okay.
No, we see them now. We see them now.
Okay. So what I was saying is that these risk prediction models are useful in research, but not really in individual patient decision making. And therefore, while scoring systems are proved useful for gauging the immediate impact of disease, they all share caveats of imprecision that limit their use and accuracy in prognostication, clinical decision making. And I think that's something which across the board most people agree on. So how do we really define devastating brain injuries? So what we do is we define this when a patient has a GCS of 3 to 4, when the pupils are dilated and not reacting, when there is a CT scan evidence of a brainstem infarct or an MRI evidence of medullary injury or a bilateral pontine injuries. Now this actually forms the definition of a pure devastating head injury. All other combinations would not be a devastating head injury, but you can call them catastrophic injuries or serious injuries. Now, what the Neurocritical Care Foundation have recommended in this paper in 2015 is that don't make an observation or decision based on a single clinical finding. You need to observe the patient, and therefore you need to do repeated examinations over a period of time to establish greater accuracy, and they recommend a 72-hour observation period before you decide on taking a further step. Also recommended in this journal from Critical Care that it is very important to have a protocol in each institution to look after these patients and manage these patients. You can't make everyday case-to-case decision just out of the box. You need to have a protocol whereby all members of the team are guided. by that protocol, and therefore, and this is associated with an improved survival in serious patients. And therefore, we have suggesting a certain protocol. This is what we use at our institution. What we have is first the determination of the severity of injury, which is done by 3 clinical points and 1 radiology point. The clinical points are that of the Glasgow Coma Score, the pupillary size and reaction to light, and the brainstem reflexes. And we also look at, after that, the radiology, which is the CT scan finding. When you take these 4 points and put them together, you come across 4 scenarios of devastating injuries. So if you look at the devastating injury scenario 1, it comes with pupils dilated, not reacting. You have the brainstem reflexes absent, with radiology showing a brainstem infarct. Now, the recommended action for this is that if it is the same after 48 hours, then you need to plan for maintenance of organ perfusion and declaration of brain death. Scenario 2 is when the pupils are dilated and not reacting, the brainstem reflexes are absent, but there is no brainstem infarct on radiology. Then the recommended action is aggressive treatment for at least 48 hours. It may be surgery, it may be just medical treatment, but for 48 hours you give aggressive treatment, relook at the patient, and then decide on further management. Scenario 3 is when the pupils are reacting, brainstem reflexes are present, but radiology shows a brainstem infarct. Once again, aggressive medical and surgical treatment for 48 hours at least, relook at the patient, and then take a decision. Scenario 4 is, of course, when the pupils are reacting, brainstem reflexes are present, there is no brainstem infarct, you need to continue aggressive medical and surgical management, and these are patients who would definitely show some improvement in survival. And therefore, we come to a definition which is guided by the GCS, the pupils, the brainstem reflexes, the radiology, which is CT mainly. MRI is used only when we are not sure, after a period of time, after 48 hours or so, when we really want to know and prognosticate to help the family decide on further management. Otherwise, I don't think MRI is of use in the initial management of these patients. Aggressive management and maintenance of perfusion of organs is very, very important in these patients. Nihilism must be avoided, and we must look at how to manage these patients, because a significant number could be saved, and otherwise we could maintain the organs for organ donation. So in conclusion, we need to avoid nihilism regarding so-called devastating head injuries, because a good percentage do survive. Maximal critical care, aggressive management is required by both the critical care and the surgical team for at least 48 hours, where you need to relook at the patient. I don't think we should take decisions the minute the patient comes into the ER and is shifted under neurosurgery or under neuro ICU care. And even if the patient is beyond survival, I think maintenance of organs is very important. I think this is my last slide. Thank you very much for listening.
Okay, Professor, thank you very much for an excellent talk. Well presented, very clear slides. And coincidentally, we have a couple of patients that are going to be speaking in a couple of hours, matter of fact, in about 4 or 5 hours. And they're going to kind of give their side of the story about what it's like to have a traumatic brain injury and what it's like to recover, etc. Okay, Ramesh, do you have comments or questions for your buddy?
Sridhar, that was a great talk, and the way you analyze all these papers, I think that gives a perspective about what is important in cases like this. And the institution I work, which is the Imperial Trust, and the major trauma center we have participates in the head injury trials in combination with Cambridge, and some of the papers you have presented is from Hutchinson, who we know very well.
Yeah. The problem, my interest in this came about because we found that very often even patients who are serious and not really devastating in inverted commas are often given very negative uh, uh, prognostications. And that's the sad part. And I think this is what we need to send out to the neurosurgical population.
Yeah, I completely agree. And one other point which I was very, which I think needs to be emphasized is a protocol-driven management, which definitely changes the outcome.
Very true. Very true. Very true.
Yeah.
I think what is also very important is that you need to be in complete sync with not only the ER but also with your critical care colleagues. That's very important. If that doesn't happen, then very often each one has their own philosophy, and so it has to be these three, I think, compartments who manage traumatic brain injury have to be in complete sync and work together.
Absolutely. Yeah, totally agree.
Excuse me, Ike, do you have any comments or questions for Professor? You're muted, Ike. You're muted, Ike. Ike, you're muted.
Can you unmute it?
Unmute yourself. There you go.
Yeah, hi, Sridhar. How are you doing? I was listening to your talk. Very interesting. I agree with you completely. A few things I wanted to ask you. What's the scenario of head injuries in Chennai at the moment?
Chennai has got a very bad reputation as far as head injuries go because India tops the list of head injuries following road traffic accidents, as you know, in the world. And I think our state is number 2 in the number of head injuries. So that way the scenario is very bad, and I think in the program I saw a talk on prevention. So I think that's a very important thing, and that's what we're talking about all the time. As far as management is concerned, unfortunately, I think what is missing is the protocol-driven management of head injuries. It is often depends on the individual neurosurgeon's thinking or what he or she thinks at that point of time, or what the ER physician thinks at that point of time. It's across the board, both in private and in government institutions and academic institutions, because for many reasons. It's for space, for finance, for manpower. There are many reasons for this. But I think we need to slowly change the thought process more than trying to make everything right. I think we need to start looking at changing thought process towards making people look at unified protocols across the board, and that would then bring everybody back on the same page, and then maybe things would become better.
I've been to Chennai for a couple of times, and I know it's decompressive hemicraniectomy is the protocol, but then I saw a few decompressive hemicraniectomies for subdurals, which I mean, I wouldn't say not warranted, because it is a procedure in place right now. But I was wondering if you have had any experience with opening systems in decompressive.
Yes, after I met you in Delhi, we have actually started doing a trial look. We are doing the decompressive craniectomy because that's what we do, and in addition, we are doing a cysternostomy. So what we are trying to do, we are looking at about 30 to 40 cases before we analyze our results. We are trying to look at what the outcomes are with the cystonostomy as opposed to the cases which we have done before without the cystonostomy. So this is what we are looking at presently, and let's see. I'll
Yes.
come back to you with the results.
Yes, yes, I'd be very interested. I would be really, really interested to know about these. This would classify. I mean, are you opening the membrane of request as well?
Yes, yes, yes.
All right, right. So this would be
So
proper.
what happens is that the decompressive craniectomy is done, the acute subdural is evacuated, and then we go down to the base, open the optic cistern, the carotid cistern, and then go down in the optico-carotid space, and then go down to the membrane of Lilliquist.
Fantastic. So you have found the brain to be lax after this?
We have found the brain lax, but
Yeah.
I'm more looking at results in GOS after doing this and looking at an overall picture as to what were the problems, because everything is noted down. So let's see, let's finish our 40 cases and then come back and see what the results are. We've had some problems. We've had some problems where we've not been able to actually get down to the base. Sometimes, in a couple of cases, I think they called me in, and it's been a little bit of a struggle to get down to the base. Maybe because we didn't drill right down. The person who did the craniectomy didn't drill right down. We're looking at all the aspects of this, and we want to analyze our figures first before I really make a statement on this.
I understand. I completely understand. Yes, I agree with you that sometimes it's almost crazy to, in a very tight brain, to go into the base. But I mean, I would like to show you probably a video as to, you know, as to sometimes how bad it can be.
Yeah.
Do you have the video now? You want to show it now, Ike?
Yeah, John. I would just.
Oh, okay.
Can I screen share?
Yeah. Sometimes it's successful with video, sometimes not. Sometimes I have to embed it on a web page. But if you send me the address to it, I can post it up. Well, there you go. Yeah, we can see that.
Right.
Yeah, they're very good.
That's an acute subdural which we evacuated. I mean, you can see when the dural opening is there. Can you see how?
Yeah.
Sridhar, can you see how bad the dural opening is?
No. Yeah. Now I can see that. Yeah.
Yes. Now we are evacuating. That's a 2.5 centimeter incision, and we are evacuating the subdural. And I've gone down to the opticocarotid cistern, and then I just wanted to show that we are opening the dura after that, and then I complete the cystonostomy, and then the brain is very, very lax after that.
Yeah,
I mean, even now the brain is a bit full, but once I complete the cystonostomy and put in the drain, the brain will become very lax right now.
Yeah. We most often we are successful. I think it's only in a couple of cases where it's been terrible.
I'm showing you a terrible case after. See how lax the brain is now. See how lax. Yeah. Very lax. I'm going to show you another terrible case. Immediately after this, I'm just see that is a burst slope with very high ICP. Then here no cisterns were seen, nothing was seen. So we went to the base. You see the brain coming out there. I'll show you. You see that?
Yeah.
That's as terrible as it gets. But you can see once I go into the base, you can see the damage of this damage which is there. But once I go into the base, you can see the CSF welling up.
Yeah.
I mean, this keeps on welling up. So this is we have just published the CSF shift edema, which is a different type of edema, which we say that it's only seen in trauma and subarachnoid hemorrhage, and so it's completely different from hydrostatic and vasogenic. And you see at the end of the closure, you see how lax the brain is.
I think the key to this is taking your craniotomy right down to the base and drilling it so that you can get right down.
Absolutely.
Even if you have a ledge of brain, that's going to be very tough.
Yes, absolutely, absolutely, absolutely.
Yeah.
Thank you.
Well, very good. We have to move on to our next talk. So I appreciate Professor spending the time to talk to us, and thank you to the guests for coming.
Thank you.
And we'll see you at the next conference.
See you.
Sure,
Bye
Sridhar.
bye.
See you. Bye bye.